Hello, everyone, and welcome. Today, we are going to dive into a very, very important chapter in cardiovascular pharmacology, the anti-anginal drugs. Now, this is not just some high-yield topic for your exams, okay? Understanding these drugs is absolutely fundamental for your entire clinical career. So let's get started. First things first, let's ask the most basic question. What is angina, really? You know, that crushing chest pain, what is it? It's basically a distress signal. It's the heart muscle, the myocardium, literally crying out for help because it's not getting enough oxygen for the work it's doing. This mismatch, this imbalance between oxygen supply and oxygen demand, that is the entire problem we are trying to solve with these drugs. Simple. So, here's our game plan for today. We'll start with the classic nitrates, our first responders on the scene. Then, we'll move on to the beta blockers, which are like the work reducers for the heart. After that, we'll cover the super versatile calcium channel blockers. And finally, the most important part, we'll see how to put it all together for a patient. Ready? Let's begin. Okay, first up, the nitrates. I want you to think of these as the ambulance service for an angina attack. When a patient is clutching their chest, feeling that intense pain, these are the drugs that give that incredibly fast, life-saving relief. So, what's the fun to hear? How do they actually work? Well, it all comes down to one magic molecule: nitric oxide, or NO. Nitrates are basically donors of nitric oxide. This NO is a potent vasodilator, but pay attention here, this is the key point. It primarily dilates the veins. Now, by dilating the veins, more blood just pools in your arms and legs, and less blood returns to the heart. This is what we call reducing the preload. Imagine your heart is a water pump. Reducing preload is like reducing the amount of water flowing into the pump. The pump simply doesn't have to work as hard, right? Simple as that. Now, what's really important for you to understand is the variety. You have to know the difference. Look at GTN, glyceryl trinitrate. When you give it sublingually, under the tongue, its action is lightning fast. It works in minutes, perfect for stopping an acute attack. But then you have these longer-acting oral forms, like isosorbide mononitrate. These are not for emergencies, okay? These are for prophylaxis, to prevent attacks from happening throughout the day. The route and duration are everything. Now listen up. This is a concept you absolutely have to know. It's a guaranteed Viva question, I'm telling you. Tolerance and dependence are not the same thing. Tolerance means that if you use the drug continuously, its effect starts to decrease. To avoid this, we give patients a nitrate-free interval, usually at night while they're sleeping. Dependence is much more serious. If a patient has been on long-term nitrates and suddenly stops them, poof, they can get a rebound coronary artery spasm. So the take-home message is, you must always withdraw nitrates gradually. All right, let's switch gears and move on to our next class, the beta blockers. Now, if nitrates are the emergency ambulance, beta blockers are like the long-term fitness plan for the heart. They use a completely different strategy to solve that same old oxygen supply-demand problem. And here we have a very common misconception that even the best students make. You'd think that all anti-anginal drugs must dilate the coronary arteries, right? But look at this. Beta blockers do not. In fact, they might even slightly reduce the total coronary blood flow. So if they aren't increasing the oxygen supply, what on earth are they doing? How do they help? This slide explains their genius perfectly. Beta blockers work on the demand side of the equation. They are anti-adrenergic. They block the beta receptors on the heart, which does three things. 1, it slows down the heart rate. 2, it reduces the force of contraction. And 3, it lowers the blood pressure. All three of these actions decrease the total work the heart has to do. That means it needs less oxygen, especially during stress or exercise. They basically make the heart more fuel efficient. And this is the money slide. This is the single most important thing to remember about beta blockers. While other drugs are excellent for relieving symptoms, beta blockers are the only ones that have been proven to reduce mortality and actually prolong the life of patients with coronary artery disease. This is why they are a first-line therapy. They aren't just treating angina, they are literally saving lives. All right, on to our third and final major class for today, the calcium channel blockers, or CCBs. As the name suggests, what do? They block calcium channels. And since we know calcium is absolutely essential for muscle contraction, these drugs are fantastic at telling muscles to just relax. And this applies to the smooth muscle in blood vessels and the muscle in the heart itself. Now, it's not that simple. Not all CCBs are the same. We can divide them into three main chemical families. First, you have the phenylalkylamines, and the main guy here is verapamil. Then the benzothiazepines, represented by diltiazem. And finally, the biggest family, the dihydropyridines, which includes very common drugs like nifedipine and amlodipine. And as we're about to see, their actions can be quite different from each other. This table is the key to understanding them. Look at nifedipine. It's a fantastic vasodilator. See the +++ for vascular relaxation? Because it's so potent, it causes a drop in blood pressure, which then triggers a reflex tachycardia, so the heart rate actually goes up. Now compare that to verapamil. It's a less potent vasodilator, but it has major direct effects on the heart itself, decreasing heart rate and AV conduction. Diltiazem is somewhere in the middle. So you see, you can't just say CCB, you have to know which one you're talking about. So how are they actually blocking the channel? Well, this diagram shows the life cycle of a calcium channel. It goes from a resting state to an activated or open state, and then to an inactivated state. The CCBs, they prefer to bind to the channel when it's in the open or inactivated state. And drugs like verapamil and diltiazem, they also slow down the recovery of the channel back to the resting state, which helps explain their effects on heart rate. So, to simplify things, you can think of CCBs in two main functional groups. You have the dihydropyridines, like nifedipine. Think of them as the vascular specialists. They are potent vasodilators that work mainly on the arterioles to reduce afterload. Then you have the non-dihydropyridines, verapamil and diltiazem. They are more like the jack of all trades. They work on both the blood vessels and the heart muscle itself, reducing heart rate and contractility. Okay, so we've covered the pharmacology. We know the mechanisms. Now let's talk about the clinic. When do you actually use which drug for which patient? This is where theory meets practice. Nitrates are your #1 choice for stopping an acute attack. That's the sublingual GTN. But they're also used for long-term prevention. In the hospital, IV GTN is a lifesaver in acute coronary syndromes and acute heart failure. And look at these other cool uses: biliary colic, esophageal spasm, and even cyanide poisoning. A very versatile drug indeed. Beta blockers, as we said, are first line for stable angina, mainly because they improve survival, especially after a heart attack. They're also used in unstable angina to calm the heart down. But please remember this critical contraindication: variant or vasospastic angina. In this condition, using a beta blocker can actually make the coronary spasm worse. You must remember this for your exams and for your patients. And what about the CCBs? Well, they are effective in both classical and variant angina. Why? Because they are great at preventing spasm. The long-acting ones are excellent antihypertensives. The non-dihydropyridines, like verapamil, are used for arrhythmias. And because they block vasospasm anywhere in the body, they're also used for conditions like Raynaud's phenomenon. Please, everyone, if you remember nothing else from today, remember this slide. These are two combinations that can kill a patient. Never, ever give nitrates to a patient who has recently taken sildenafil or other similar drugs. Both are vasodilators, and together they can cause a catastrophic drop in blood pressure. Similarly, combining a beta blocker with verapamil can cause severe bradycardia and even complete heart block. These are absolute contraindications. So let's do a super quick recap. The core funda for each class. Nitrates are primarily venodilators. They reduce preload. Beta blockers reduce the heart's workload. They are work reducers. And CCBs are primarily arterial dilators. They reduce afterload, with some also directly depressing the heart. Preload, workload, afterload. Got it? That's the whole story. And we'll end with a little clinical puzzle for you. You have a patient in front of you. He has stable angina, and he also has high blood pressure. Based on everything we've just discussed, the mechanisms, the benefits, the side effects, what would be your ideal choice or combination of drugs for him? Think about it. That's how you start to think like a real doctor.
Hello, bachcho, and a very warm welcome to our masterclass on advanced anti-anginal therapy. Today, we're going to go beyond the basics, the first-line drugs you've already learned. We're going to dive deep, really deep, into the strategy of how you manage those really complex cases.
So let's just jump right in with a scenario, a situation you will, I guarantee you, face in your wards. You have a patient. Their angina just is not getting better on that one drug you've prescribed. So now what, doctor? What's your next move? Believe me, this is where a good doctor, a great doctor, truly shines.
Okay, so here's our game plan for today. First, we'll master the art of drug combinations. Then, we'll meet some of the newer, smarter drugs out there. After that, we'll uncover a really dangerous trap called coronary steel. We'll also take a quick detour into peripheral vascular diseases, and finally, we'll tie everything together into a solid clinical strategy you can actually use.
All right, first up, the art of drug combinations. You see, when that one single drug isn't cutting it, you have to start combining them. But it's not just about, throwing more pills at the problem. It's about combining them intelligently, creating a powerful synergy where the whole is much, much greater than the sum of its parts.
Now look at this. This is just beautiful. This is why combining a beta blocker with a nitrate is such a classic move. You see, a nitrate on its own can cause that reflex tachycardia, right? The heart rate shoots up. Well, guess what? The beta blocker completely blocks that. On the other hand, the beta blocker might increase the size of the ventricle a bit, but the nitrate counteracts that. It's like they were made for each other. They perfectly balance out the bad stuff, giving you only the good stuff, a much better outcome for your patient.
Okay, listen up. This slide, you need to remember this for your entire life. This is the funda, the absolute core of angina therapy. You've got three main players, each doing something different. Nitrates, they mainly hit the preload, reducing the blood coming back to the heart. Calcium channel blockers, they focus on the afterload, the resistance the heart is pushing against. And beta blockers, they work directly on the heart itself, slowing it down, reducing its workload. Three totally different mechanisms, three powerful tools in your kit. Simple.
Okay, so we've covered the big three. But what happens when even they aren't enough? Well, that's when you bring out the specialists. Let's meet some of the newer agents. Think of these as the advanced weapons in your pharmacology arsenal for those really tough, resistant cases.
First on our list is nicorandil. Now this is a very, very clever drug. It's got a dual action, a 2-in-1 punch. First, it opens up potassium channels, which makes the blood vessels relax. But, and this is the cool part, it also acts as a nitric oxide donor, just like our old friend the nitrates. So you're getting two powerful vasodilator mechanisms from one single molecule, a great way to hit both preload and afterload.
Next up, we have trimetazidine. This one is, well, it's really smart. It's a metabolic modulator. It doesn't mess with blood vessels directly. Instead, it works on the heart's fuel supply. It basically tells the heart muscle cells, hey, stop using so much fatty acid for energy. That stuff is an oxygen guzzler. Switch over to glucose. It's way more oxygen efficient. So, you see, without touching the blood pressure or the heart rate, it just makes the heart better at handling low oxygen situations. Very clever.
And then there's ranolazazine. This one is also pretty unique. Unlike almost everything else we've talked about, it doesn't touch the hemodynamics. I mean, no change in heart rate, no change in blood pressure. So what does it do? It works right down at the cellular level, inhibiting something called the late sodium current. The end result? It stops the struggling heart cells from getting overloaded with calcium, which gives them a direct protective effect. It's a bodyguard for the heart cell.
And last on our list of new agents, we have ivabradine. Think of this as a sniper rifle. It's a pure heart rate lowering drug. It has only one target, the funny channels in the heart's own pacemaker, the SA node. It just selectively blocks them. This is the perfect drug to grab when you absolutely need to slow the heart down, but for some reason your patient just can't take a beta blocker. It's precise, it's clean, it's a very targeted action.
Okay, everyone, I need your full attention for this next part. Pay close attention, Bachon. This concept is fascinating, it's clinically vital, and it's a huge favorite for examiners. We're talking about a true pharmacological paradox, something you have to understand, otherwise you could actually cause harm.
So, let's meet our drug of interest here, dipyridamole. Now, if you just read about it in a book, you'd think, wow, this is a powerful coronary vasodilator. This should be a fantastic anti-anginal drug. But here's the twist. In a real patient, it can actually make the angina worse. So the big question is, why? Why does this powerful vasodilator fail so spectacularly?
And this picture explains everything perfectly. Look at panel A. You've got your blockage, your atheroma, and the poor ischemic area of the heart that's starved for blood. Now look at B. This is how a smart drug like a nitrate works. It dilates the bigger vessels, the main highways, to get more flow to that sick area. But now look at panel C. This is dipyridamole. It dilates all the tiny little side roads, the resistance vessels, everywhere. So what happens? The blood takes the path of least resistance and gets diverted away to the healthy parts of the heart, effectively stealing the blood from the very area that needs it most. That's coronary steal.
So there you have it. You're literally stealing blood from where it's needed the most. Mark my words, this is a classic exam question and a classic clinical trap. The biggest lesson here? Not all vasodilation is good vasodilation. You have to be smart. You have to be specific about which vessels you target. This right here is the essence of thinking like a clinical pharmacologist. All right, so we've spent a lot of time talking about blood flow to the heart. Now let's just briefly zoom out a little bit, because many of these same ideas, these same principles, apply when we're managing peripheral vascular diseases, or PVDs. It's a really logical next step. And this slide just gives you a quick map of the different strategies we use. You'll see a lot of familiar faces here, right? We have different kinds of vasodilators, just like for angina. We have antiplatelet drugs to stop clots from forming. But there are also some unique players, like these rheological agents. A drug like pentoxiflin, for example. It actually changes how flowy the blood is, its physical properties, to help it get through tight spots. So again, it's a multi-pronged attack, just like we saw with the heart.
Okay, we have covered a lot of ground today, haven't we? We talked about combinations, these fancy new agents, and even dangerous paradoxes. So, let's put it all together. What is the final practical strategy for you, the clinician of tomorrow?
And this is what I want you to leave with today. Remember this, always. Your textbook, it gives you a list of options. It gives you the drugs. But it is the doctor who makes the choices. You have to choose the right drug for the right patient at exactly the right time. So please, understand that managing angina effectively is not about memorizing a list of names. It is about becoming a true therapeutic strategist, a chess player, for every single patient you see. That is your real challenge and your real responsibility.